Thank you, and welcome to this afternoon from me. I'm Judith Bubbear. I'm a consultant in metabolic bone disease at the Royal National Orthopaedic, and I'm going to sort of set the scene for us for what I hope will be a really interesting afternoon. And thank you to the organisers for inviting me to speak. This might seem a slightly unusual title. It comes from an opinion piece from a board member of the European Institute of Women's Health. And in that, she asks the question, are we ignoring osteoporosis in women because of a degree of gender blindness? Which I thought was an interesting place to start. But I've given myself actually a sort of subtitle to maybe get us into thinking a little bit about this topic, to think about what is normal aging. And I'm just going to cover some of that. So just to share my disclosures, as I have had consultancy and speaker fees from a number of drug companies. In this talk, I won't be speaking about drugs. I will be in a later talk, but they've obviously had no influence over things today. So let's think about aging and the epidemiology. And we hear about it all the time that the population is getting older. But here are some statistics from the World Health Organization. So in 2020, for the first time, the number of people aged over 60 outnumbered the children who were under 5 in the whole world. And between 2015 and 2050, the proportion of the world's population over 60 is nearly going to double. So it's going to go from 12% to 22%. But when we look at the genders, we know that women live longer than men, but they are frailer and they have worse health towards the end of their lives. Another interesting fact really here around aging is that in 2050, 80% of the older people in the world will actually be living in low and middle income countries. And obviously that poses us a whole load of challenges, probably too much to go into today, but something to be considering. So I thought I'd set the scene, and many of you will know this information, but really to think about the UK. So we've thought about the world, we've thought that the population is getting older and that more people in what we might call developing countries are going to be older. But what about in the UK? Well, when I first was giving talks on osteoporosis quite a few years ago now, we used to say 1 in 3 women would have a fragility fracture, but actually the statistics now suggest that 1 in 2 women will have 1 or more fragility fractures. And we used to say 1 in 12 men, but actually now 1 in 5 men will have 1 or more fragility fractures. So that's a slightly sobering thought. If you think about yourself, your odds of having a fragility fracture in the future are really quite high. And this comes at a big cost, which we'll come on to. But in the UK, there are over 500,000 fragility fractures a year, over 100,000 hip fractures, 86,000 vertebral fractures, and I would say those are ones that we know about, that we can currently count, and 358,000 other fractures. So that's your wrist, forearm, tibia, fibula, all the other fractures. Of the fragility fractures, 2/3 of them are sustained by women. But actually the majority of people with fragility fractures don't actually have what we'd call osteoporosis on a DEXA. And that gives us some food for thought around fracture risk, and we'll come on to think about that. But when we think about osteoporosis as defined by a T-score of -2.5, the prevalence in over 50s in the UK is quite high. So 6.8% of men and just over 21%, so 1 in 5 women will have osteoporosis. And that's obviously a lot of fractures, and that comes with a lot of cost. So when I think about cost, I'm thinking about it in 2 different ways. Firstly, the cost of the economy. In today's NHS, there's no hiding from the fact that healthcare costs a lot of money, and we have to be mindful of how we spend it. So these statistics are taken from the National Osteoporosis Guideline Group that I'll mention plenty of times this afternoon. But if you want to have a look, they're there. The NHS cost of fragility fractures is almost £5 billion. And about half of that is directly incurred after the incident fracture. So that would be admissions to hospital, operations, healthcare, hospital appointments, and those type of costs. But then obviously there's institutional care costs. So that's the increased number of carers, the admissions to care homes. And that is about £1.7 billion. Wrapped up all together, that's currently somewhere between 2 and 3% of our healthcare spending in the UK. So a big proportion, might seem small, but a big proportion of healthcare is on fragility fractures. Also, when we think about cost, we want to think about the cost to the individual. So obviously fractures come with pain, fractures come with increased disability. We know that 1 in 5 patients who have a hip fracture will pass away in the year after. We know that the majority of patients who have a hip fracture will not return to their previous level of function. And there's a financial cost to the individual as well. There may be loss of earnings or need for additional care. There's this figure called this measure called disability adjusted life years. And the cost of fragility fractures is 24 DALYs per 1,000 people over the age of 50. Now that doesn't mean very much to us probably, but it's comparable to the cost of dementia in the UK. I wanted to come on to think a little bit about what we think is normal. And I was reflecting on my clinic and how it is human nature to downplay our risks. So these are things that have been said to me by patients after they had a fracture. So they very frequently say, oh, I fell very hard or badly or awkwardly. They might say, oh, it was a concrete floor or it was very hard. They might say it's healed up okay. And they almost all say, I'm being very careful now not to fall. The unfortunate thing is all those changes in behaviour, they don't actually reduce our fracture risk. Obviously we can be careful not to fall, but there are fractures that will happen without fall. But it's human nature to play down risk, and I think this might be one reason why women might assume it's normal to fall over and have, for example, a wrist fracture or even a hip fracture. So what is normal anyway? I thought I'd take this dictionary definition from the Collins Dictionary. So normal is something that's usual and ordinary. It's what people expect. And it defines a normal person as someone who has no serious physical or mental health problems. When we think about normal as doctors, we often think about a normal distribution, and this is a really familiar concept to us with osteoporosis and standard deviations for RT scores. But what is normal aging? Is it reduced mobility? Is it height loss? Is kyphosis normal? Are falls normal? Are fractures from a fall normal? Are fractures without a fall normal? What is normal aging? Maybe it's what we expect. That's what that definition said. So I wondered if we might be thinking about it a different way. I love these two quotes. Karl Lagerfeld said, I don't know what normal means anyway. And the great Morticia Adams said, normal is an illusion. What is normal for the spider is chaos for the fly. And I think increasingly our understanding of the world challenges our concept of what's normal. So maybe we don't want to think about normal aging, and maybe we want to think about healthy aging instead. And this definition from the PAHO, which is an American health organization, I thought was helpful. So it defines healthy aging as a continuous process of optimizing opportunities to maintain and improve physical and mental health, independence, and quality of life throughout the life course. And I don't know about you, but as I get a bit older, I prefer to think about healthy aging like this, to think about optimizing my opportunities to keep healthy, rather than to think about normal aging being some sort of path that I'm going to tread and it doesn't really matter what I do. And then I was interested when I was looking at healthy aging, and actually the World Health Organization has made this decade the UN decade of healthy aging, which is obviously ties into the fact that the population is getting older, so we want a healthy population. So I'd just like to suggest to you this afternoon that osteoporosis might be part of normal aging, but that its management should be part of healthy aging. And I'd like to suggest a life course approach. And I'll touch on this about prevention. How do we optimize bone health in our young people and young adults? Then we might think about screening. How do we look for people who might need treatment? And then we want to think about treatment. And increasingly, we have good options for treatment. And we want to make sure we're doing the right thing at the right time to the right person and giving them the best treatment. So just before I close, when I was thinking about gender blindness as well, I wanted to just have a word about back pain. I'm not sure we're going to cover it through the rest of the day. And I was just reflecting on vertebral fractures and how important they are. We're all taught at medical school about red flags, but what we're not taught, or not necessarily taught, is that red flags are there to pick up cancer. That's how they were decided upon, and they're pretty good at picking up cancer. But they don't perform so well when we're thinking about vertebral fractures. Back pain is obviously incredibly common, but I think it's important for us to think about vertebral fractures if we've got a patient with back pain. Actually, when I went on the NHS website to look at back pain, the things that ask for an urgent GP appointment, including pain that doesn't improve with rest or worse at night or worse when sneezing, coughing or pooing, may actually be things that would highlight a vertebral fracture. But I think we do need to keep this in mind. So I'll bring this to an end, just an introduction, hoping to set the scene, maybe to make us think about how we can help our patients to age healthily and how we can do the best to treat osteoporosis and prevent fragility fractures. Thank you very much.